Is a pilonidal abscess just a pain in the bum? Hi, it's Dr. Fan here. Let's talk about pilonidal disease. This is a condition of the skin and subcutaneous tissue. It includes pilonidal sinuses, tracts, and abscesses. It most commonly occurs in the natal cleft, but also can occur in the interdigital spaces or the umbilicus. The natal cleft is a groove between the buttocks, extending from the sacrum to the perineum. A pilonidal abscess in this area is still a skin condition, even though it is located near the anal region. This condition has an incidence of around 25 in 100,000. It typically affects those aged around 20 and has a slight male predominance, being 2 to 4 times more common in males. Pilonidal disease results from having pits in the natal cleft. Hairs fall into these pits. These hairs do not have to originate from around the pits and can fall from anywhere, including the back of the head. The friction of these hairs drill deeper into the pits to form a sinus. These sinuses typically extend under the skin towards the head, but can go in any direction. Risk factors for pilonidal disease include having obesity, a sedentary lifestyle, local trauma, deep natal clefts, high hair density, hard straight hairs, and a family history of pilonidal disease. Pilonidal disease presents acutely as a pilonidal abscess with inflammation, pain, erythema, and swelling. People with recurrent acute attacks develop chronically inflamed sinuses that present with persistent discharge and pain. Diagnosis is clinical and is best treated in the hospital. An acute abscess should be drained and may be packed with packing gauze if there is a deep cavity. The packing allows areas of deep infection to drain out along the pack, much like a wick. If the incision is made large enough, the pack can generally be removed the next day and the drained area can just be washed regularly in the bath or shower to keep the area clean. Eventually, the cavity will fill with granulation from deep within the cavity. Antibiotics may be required if there is surrounding cellulitis. If there are recurrent infections or chronic tracts that have persistent discharge, an operation may be required to remove these tracts. The underlying principles of these operations are to excise the tracts and leave a defect, or to excise the tracts and repair the defect with a local flap. Simple excision techniques include pit excision, whereby the tract is probed and the whole area is cut out, and marsupialization of the tract, whereby the area is opened up and the edges are rolled back and sutured to keep the defect from closing too early. A variety of dressings can be used to fill these defects, ranging from simple gauze dressings to vacuum suction dressings. These techniques all have about 60 to 80% long-term success. Reconstruction flaps have many options, of which the most popular is the Caridacus flap. This involves targeting one side of the natal clefts with an off-midline excision of the tracts down to the presacral fascia, then undermining the skin and subcutaneous fat from the other side to close this defect. This has around 95% long-term success. The Bascom cleft lift is a similar procedure, but the excision is more limited and does not extend down to the presacral fascia. Other reconstruction flaps include Z-plasty, rhomboid, VY, rotational, and keystone. These again can vary in their depth of excision. Postoperatively, the patients should have minimal activity for 2 to 3 weeks due to the high tension required to close these flaps. The sutures should also stay in for around 3 weeks due to this same high tension. Well, I hope that you have learned something new. Please listen to this again to reinforce your learnings, because repetition is part of learning new information. And remember to like, subscribe, share, and comment for more videos.